Hi, this is Mark Prussian from Butchertown Clinical Trials. Thanks for joining us today to listen to our webinar entitled Past, Present, and Future of Dry Eye Disease. Our primary speaker will be our principal investigator, Dr. Guru Prasad R. Patar, MD, PhD. And in the meantime, I, Mark Prussian, am going to give you a little bit of information about Butchertown Clinical Trials, where we state we have higher enrollment and better data. A little bit of housekeeping information before we begin. Our presentation will be about 30 minutes. We're going to ask you to submit any questions you may have via the Q&A function on our webinar program. We will attempt to answer as many questions as we can during the 30 minutes we are allotted. And for any remaining questions we don't answer, we will get back to you via text, phone, or email address within about 48 hours. So with that, let me tell you about Butchertown Clinical Trials. We are a clinical trial site associated with an ophthalmology practice called the Eye Care Institute. Before you tune us out right there, let me say we do more than just ophthalmology. We do primary care and endocrinology clinical trials as well. We began in 1984 with a commitment to serving our local area for eye care. Almost 20 years ago, we expanded our practice and started a small clinical research division with just 1 or 2 employees at a time. It has significantly expanded and has its own name, Butchertown Clinical Trials. It's got its own building on our medical campus. We have expanded to the point where we have shepherded 15 drugs or devices through the FDA approval process. It's in a dedicated research facility on our 21,000 square foot medical campus. We have many additional features. We have 2 primary care lanes for trials in the areas of nutrition, endocrine and diabetes, artificial intelligence, cancer registries, and more. We have one of the largest clinical trial centers for ophthalmic drugs and devices, probably one of the largest in the United States, with lots of specialized equipment testing. We have a procedure room. We have dedicated monitored IP storage. We are on a backup generator system to monitor and control our IP levels for temperature and so forth. And we are consistently ranked extremely highly by the monitors who visit us from sponsors and CROs. We're going to have an agenda today that's going to teach us a little bit about one of our areas where we've done a lot of trials by way of example, so that you can see that we are a sophisticated, up-to-date site. It's going to up-to-date site. We are primarily going to speak about dry eye facts with Dr. Patar and some of the treatments and trials we have done. And as we said, we'll have some questions and answers. So let me tell you a little bit about Dr. Guru Prasad R. Patar. Dr. Patar is from Indianapolis, Indiana. He is a huge Indiana sports fan, whether it's the Pacers, the Colts, or Indianapolis or IU college sports. He attended college at Creighton University in Omaha, Nebraska. He has his medical school, his ophthalmology residency, and a PhD, each from Indiana University. He is a Hoosier through and through. He is a huge music fan, loves outdoor concerts and so forth, has a wonderful family. He is a girl dad of 3 cute little girls and has dogs and has a great life. So now I present to you Dr. Guru Patar.
Thank you, Mark, for that wonderful introduction. I'm happy to be here today to present on one of the most common ophthalmic conditions that we see in our office today, which is dry eye disease. As many of you know, dry eye disease affects many people worldwide. Statistics show that it can actually affect up to 334 million people globally. And in the United States, almost 10% of the population is affected by dry eye disease. Clinically speaking, dry eye disease is a multifactorial disease. It involves the tear as well as the ocular surface. Symptomatically, patients can experience discomfort. They can have problems with their vision, and usually this is fluctuations in their vision, as well as instability of the tear film, which patients can't necessarily appreciate, but ophthalmologists and optometrists do see this regularly in the office. If dry eye disease gets to the severe stage, this can result in permanent damage to the ocular surface. This also does include susceptibility to eye infections, as well as I mentioned before, permanent damage to the ocular surface. On a more sort of important role, though, dry eye disease has been shown to affect activities of daily living. And this does include many things that people need to function, such as reading, as well as driving. As far as eye care professionals, what we see in the office, 91% of ophthalmologists do agree that mild to moderate dry eyes can affect postoperative outcomes. Most ophthalmologists perform cataract surgery, and cataract surgery outcomes can be affected by undiagnosed dry eyes or even diagnosed dry eyes that's not adequately treated. Additionally, this does lead to patient dissatisfaction, which then will affect their activities of daily living. As far as other eye conditions, optometrists as well as ophthalmologists do see that dry eye disease can affect the comfort and tolerability of contact lenses, as well as contact lens placement. And then finally, happiness of patients wearing their glasses can be dependent on the ocular surface. So as you can see, there is significant visual outcomes that is associated with dry eye disease. As far as the tear film goes, not very many people understand that the ocular surface is actually made up of 3 different layers. When people think of tears, they primarily only think of the aqueous layer or the water layer. But actually, on the very surface of the tear film is an oil layer. So that's the outermost surface. This is secreted by what are known as meibomian glands or oil glands that are located in the upper and the lower lids. The lipid layer does provide lubrication. It helps to prevent evaporation, which will be important here in a second, as well as it helps to protect the eye from infections and things of that nature. The layer right below the oil layer is the aqueous layer or the water layer, and this is what we classically think of as a tear. This is produced by the lacrimal glands, which are located sort of in the upper outer third of the lid, of the upper lid, and that's where your lacrimal glands are. There are actually also glands within the lids that can produce the aqueous layer. This is the bulk of the tear volume and flow, so that's why most people think of the tear as a water layer. That does contain electrolytes just like your blood does. So it'll have sodium, it'll have potassium, it'll have chloride. It does have proteins in it. And then growth factors that help to actually protect the corneal surface, which I will describe here in a little bit. Finally, underneath the water layer is the mucin layer. And this is really just a protein layer that is produced by the goblet cells found in the outermost part of the eye, known as the conjunctiva. This is really there to provide protective functions for the corneal surface as well as the ocular surface to prevent infection, to allow for healing, and to provide things like hydration and things of that nature. Now, the tear film is really there to protect our corneal surface. Now, the cornea is actually the layer of the eye that provides 2/3 of our vision. The cornea is essentially just clear skin. So the very front surface of the cornea is just known as the epithelium, which is the skin layer. And then there is a larger portion of the cornea known as the stroma, which is right underneath the skin, and then a water pump layer known as the endothelium that helps to keep the cornea dehydrated so that you can see through it. Now, if you have a defect in the tear film, this can actually lead to little divots or little dry spots that are present on the cornea, and that's what we see clinically as dry eye disease. As far as mechanisms of dry eye disease goes, this is a very busy slide. I just wanted to point out a few highlights of this slide. And really, dry eye disease starts by having either not enough tears or you have enough tear production, but you don't have a good quality tear, leading to what's known as hyperosmolarity. So essentially, there are more proteins and electrolytes than there is water on the surface of the eye. This then stresses the surface of the eye or the skin layer, which then leads to all these sort of inflammatory factors, which you see here, where it says activate epithelial MAPK+, which then leads to these cytokines, which are essentially hormones released by the eye to get inflammatory cells to come heal it. The problem is with inflammation, you have collateral damage. And so therefore the inflammation leads to worsening dry eye. So there is a sort of cyclical pattern here. And once you get into that cyclical pattern, it is sometimes really hard to break that cyclical pattern there. But this will lead to sort of the treatments that we have now for dry eye disease. But let's first talk about the mechanisms or the diagnostic classification of dry eyes. So when I'm in the clinic and I'm looking at a patient that does complain of having intermittent or occasional blurring vision, they have burning and stinging, there are two main pathways that my mind goes down. And the first is aqueous tear deficiency. Now, this is essentially poor tear production. So when we're talking about the three layers of the eye, this is that middle layer, the water layer, that a patient does not have enough of. There are two main branches of aqueous tear deficiency. There's something called Sjogren's syndrome, which is essentially an autoimmune disease leading to inflammation of the tear gland, which then reduces the production of aqueous tear on the surface of the eye. There's also non-Sjogren's dry eye. So essentially that's just, for whatever reason, lack of tear production. And oftentimes this is actually due to systemic drugs. Now, I practice in Louisville, Kentucky, and one of the big things that we have in Louisville is seasonal allergies. So therefore, the majority of the population, they take some sort of antihistamine to prevent worsening of their seasonal allergies. That could be one of the reasons of non-Sjogren's dry eye, because antihistamines do essentially dehydrate the body, and so therefore they don't make enough aqueous tear production. As far as the evaporative, so this is the other big classification for dry eyes. The primary abnormality there is the meibomian glands don't function as well. And remember, the meibomian glands are oil glands that then produce an oil that sits on the top of the tear film. So the meibomian glands, for whatever reason, if it's inflammation, sometimes it's medications, sometimes it's contact lens wear, sometimes it's surgery, they can lead to obstruction of those glands, which then lead to an evaporative dry eye. So essentially, you make enough water, but that water doesn't stay on the surface of the eye long enough because of lack of oil production. Now, let's talk a little bit about aqueous tear deficiency. So common symptoms that we see here in the office are burning, light sensitivity, as well as intermittent blurred vision. For these patients, symptoms tend to be worse at the end of the day. So with prolonged use of their eyes, especially people that are looking at the computer all day long, they have a reduced blink rate, which then does not allow for enough water to be on the surface of the eye. Now, there's a picture to your left here that I just wanted to draw your attention to. As you can see, this is a picture of an eye. On the surface is the cornea. Now, this is highlighted with yellow spots on it. So this has actually had a dye instilled called fluorescein, which I'll talk about here in the future. Now, off to the left-hand side of the cornea, you can see that there is this patch of almost what looks like stars, and that's essentially fluorescein highlighting dry spots on the cornea. Signs for patients that have aqueous tear deficiency, oftentimes they'll complain of having red eyes, which does not really get all that much better on its own. In the office with the slit lamp, we will see an irregular corneal surface. So the cornea should be just like a clear glass window, but if there are signs of dry spots on there, there will be irregularity to that corneal surface. Additionally, you can actually see little debris in the tear film. So the tear film should be clear. It should be like water. Every now and then we'll see little chunks of oil, or we'll see little chunks of almost like dandruff floating in the tear film, and that can be a sign that they have some sort of dry eye. Now, moderate to severe dry eye patients can have mucus associated with this. Now, what these patients will oftentimes complain about is having pink eye, and they will have had pink eye for 2 to 3 months. Really, pink eye is only caused by a viral conjunctivitis. It only lasts for a couple days. So oftentimes I have to have the conversation with these patients that this is not this is not pink eye, but this is severe dry eye that can cause mucus associated with their dry eye. I mentioned a little bit about Sjogren's syndrome. As I mentioned previously, this is just an autoimmune disease that leads to lack of tear production, leading to aqueous tear deficiency. Now, Sjogren's syndrome can be treated by a rheumatologist because it is an autoimmune issue. So in conjunction with ophthalmologists, rheumatologists do help in decreasing the inflammation or the immune system from acting up in order to help solve these patients' dry eye problems. As far as evaporative dry eye goes, common symptoms that patients will have is burning, foreign body sensation, redness of the eyelids, because the meibomian glands are localized in the eyelids, as well as a filmy vision. So they'll complain of more filminess rather than intermittent blurring vision. Now, interestingly, for these patients, their symptoms will tend to be worse in the morning. So these folks oftentimes come in and they'll say, I wake up first thing in the morning for about 30 to 45 minutes. My vision's really blurry, but then I blink a couple times, I put an artificial tear in, then I'm able to sit down and read the paper. Now, clinical signs that we see here in the office, we can see an irregular eyelid rather than an irregular corneal surface. And then, since these patients have inflammation at their eyelids, which is why the redness is there, you can see enlarged blood vessels on the eyelids known as telangiectasias. Looking at this picture here to your left, this is just a picture of the meibomian glands. Now, the lid is actually everted, so the underside of the lid is pointed outwards. And this is a patient that has relatively severe meibomian gland dysfunction. So what you see is these shortened little white spots on the underside of the lid. Ideally, a patient that has normal meibomian glands, that those white spots will actually run from where the eyelashes are all the way to the ocular surface or to the eyeball itself. So this is a patient that has relatively severe meibomian gland dysfunction that has not been treated for a long time, leading to atrophy as well as loss of these meibomian glands. This picture is a picture of severe meibomian gland dysfunction as well. Now, you can see this is the lid, and you can see right at the lid margin, so right behind the eyelashes, there's almost this cheesy material coming out, or almost like toothpaste. Now, ideally, what should come out of those meibomian glands is just almost like a olive oil consistency. Now, this is a plugged up oil gland because of significant inflammation. So as you can imagine, this patient does have significant dry eyes because that oil is coming out as a solid rather than as an olive oil. So with all this combined, let's talk a little bit about diagnostic tests that we can do here in the office to look for dry eye disease. There are different dyes that we can use, and I alluded earlier to fluorescein dye, and that's probably the most prevalent dye that we'll use here in the office that will highlight dry eye disease for us. Another one that we use in the office regularly is lissamine green, and then rose Bengal, and I'll talk about this here a little bit in the upcoming slide. So these are pictures of both fluorescein dye, which is to your left, and then the lissamine dye, which is to your right. Now, fluorescein is good for highlighting dry spots on the corneal surface. So you put a little orange dye into the eye, and you give it about 2 minutes or so, and then it will highlight all these little dry spots. Looking at this picture, this is an actual patient picture of mine. This is somebody that has significant or even severe dry eyes. As you can see, basically you can't see any corneal surface. You just see highlighted dry spots all over the cornea. Now, as far as lissamine green is concerned, lissamine green is something that actually stains dead cells and not healthy cells. There needs to be a disruption in the mucin coating. And if you remember from my earlier slide, mucin is actually produced by the conjunctiva, or the white of the eye. So lissamine is better for highlighting dry spots found on the conjunctiva. It doesn't necessarily highlight dry spots on the cornea unless you have severe dry eyes where you have a lot of dead cells. It can be used to detect earlier or mild cases of dry eyes because it will highlight the conjunctiva earlier than the cornea. So you can catch people that have early dry eyes by using this lissamine green dye so that it can highlight a breakdown in the mucin, which will then predispose people to having the picture to your left, that severe dry eye there. As far as rose Bengal is concerned, rose Bengal is a dye that was introduced back in 1933. This can also be helpful in detecting early or mild cases of dry eye. It really has fallen out of favor because lissamine is not very toxic to the cornea, whereas rose Bengal is. So if you put rose Bengal into someone's eye, oftentimes after the first 30 seconds, it is going to severely burn and sting. So therefore, clinically, we don't use this very often because patients do complain of that burning and stinging for up to 20 minutes after installation of this rose Bengal. Other diagnostic tests, now that I've described the dyes that are used for diagnosis, one of the very first things I look at in the office is tear breakup time. So you put fluorescein into the eye, you ask the patient to sort of close their eyes, and then you ask them to open their eyes after 1 or 2 blinks, and then you count how long it takes for a dry spot to appear. Now, if you're looking at this picture to the left, which I've shown you before, at the very bottom of the cornea, you can see these little almost black-like spots there, and that is essentially a tear breaking up. And that's what we're looking for when we do tear breakup time. Ideally, people without dry eye disease will have 10 seconds or more before their tears break up. Now, people with dry eye disease oftentimes have dry spots appear within less than 10 seconds, and this is considered abnormal. The next test that I want to discuss is something that is used in both a clinic as well as almost every single clinical trial that I have done utilizes the Schirmer's test. Now, this is what's known as a basic secretion test. So this is anesthetized. So this is only going to get just basal tear production. So what you do is you put a drop of proparacaine in, which is a numbing agent for the eye. And then you put these strips of filter paper on the outer corners of the eyes, and you let that sit for about 5 minutes. Less than 3 millimeters of tearing. So the filter paper will actually collect the tears, and then there are actually marks on the Schirmer strips, which you can see here, and they represent every 5 millimeters. So less than 3 millimeters of wetting of the filter paper will be highly suggestive of aqueous tear deficiency, and this will play an important role in our treatment of dry eyes. Anything that is 3 to 10 millimeters is considered normal. Now, this is something that's easy to do in the office as well as for clinical trials because it is relatively comfortable for a patient since their eyes numb for this. I should mention that you can either do this with patients' eyes open or closed. However, most studies, as well as in my office, I like to have them close their eyes because then they're not moving their eyes around a lot. As you can see, since it's located sort of on the outer edges, if you move your eyes over to the right or left, it can rub the cornea can actually rub on the filter paper, which can then cause excessive tearing. So I like to have their eyes and their eye movement as still as possible. The next test I want to discuss is a Schirmer's 1 test, and now this is without anesthesia. This is a little bit more uncomfortable, although it's not significantly more uncomfortable. This does measure both basal as well as reflex tearing. Patients that have aqueous tear deficiency will generally have less than 5.5 millimeters of wetting after 5 minutes. Now, most clinical trials find that patients with less than 10 millimeters of wetting is diagnostic of aqueous tear deficiency. The most important reason why Schirmer's is done is because it's something objective that you can get for dry eyes, because it's independent of an investigator. It's also independent of the patient. This either a patient's going to make tears or they're not going to make tears. So this is an objective measurement that you can have for dry eyes. As far as the Schirmer's 2 test is concerned, this is something that's not routinely done, although two of the clinical trials that we participated in actually did do the Schirmer's 2 test. Now, this is somewhat interesting because you actually put anesthesia into the eye. So this is done with a topical anesthetic. It only measures reflex secretion, so it takes out the basal tear production. After you put these strips of filter paper in the lateral corners of the eyes, you then take a Q-tip and you irritate the nasal mucosa. So you put the Q-tip into a patient's nose and you actually spin that to irritate the nasal mucosa. What you're doing there is you're actually activating what's known as the trigeminal nerve in the nasal mucosa, which will then lead to reflex tearing. Now, wetting of less than 15 millimeters after 2 minutes is actually considered abnormal, which likely means that they have some sort of neuropathic component or that their trigeminal nerve isn't quite connected to their tear gland. Rudimentally speaking, kids know this because if you stick something too far up your nose, you know that your eyes start to water. Or on a less gross level, if you sneeze, that's actually activating the trigeminal nerve, and then that can lead to tearing. So a lot of folks that have a sneezing attack will then know that their eyes will water because of this. There are other diagnostic tests that are done in the clinic as well as for clinical trials. This is something called Tear Lab, and this is measuring osmolarity. If you remember from my very first slide, one of the first inciting events is actually tear hyperosmolarity. So this will be able to measure osmolarity in the tear film. If the number is high, you can predict that this patient is going to have some sort of dry eye. You can also utilize this number to see if your treatment is working as well. Tear Lab has since sort of fallen out of favor because it was not really shown clinically to show an improvement. Most folks that have hyperosmolarity will continue to have hyperosmolarity. This is another test that we can do in the office, and this sort of looks like a pregnancy test, but it's actually just a marker of inflammation. Now, one of the biggest inflammatory cytokines that's released by the epithelium is known as matrix metalloproteinase 9. And so this inflammatory is looking for presence of MMP9. Now, this is one of the things that we can look to see if inflammation is a significant contributor to a patient's symptoms and signs of dry eyes, and therefore prescribe them some sort of anti-inflammatory, which I'll talk about here in the future. Other things that we can look at are the actual meibomian glands themselves. Now, this is known as infrared meibography. As you can see, the picture on your left is actually a picture of normal meibomian glands. So you can see what almost looks like a worm-like white thing in the lid is going from the lash line all the way to the eyeball itself. And it's basically covering the whole lid. And that is somebody with normal appearing and functioning meibomian glands. The picture to your right is actually that same picture that I showed earlier of a patient with severe meibomian gland dysfunction. So you can see the difference between normal, where they have, again, it's going from the lash line all the way to the eye. On the picture to your right, it's actually somewhat truncated, meaning that it's not traveling all the way to the ocular surface, and then you're missing quite a few of these meibomian glands because they have actually died due to severe inflammation or to obstruction. Here is a quantitative picture of lipid thickness. So this can actually quantify how much lipid is on the actual ocular surface. Normal values is going to be 100 or above. You can see this patient here is roughly half of that. So likely this patient does suffer from mild to moderate meibomian gland dysfunction. Here's another diagnostic test that actually takes a patient's perspective. OSDI stands for Ocular Surface Disease Index. So basically, a patient's going to rate how bad their eyes are bothering them. And then also with activities of daily living, if you can see here on number 6, it asks, do you have problems with your eyes limiting you in performing any of the following during the last week? Reading, driving at night, working with a computer, or watching television. So they can rate their symptoms, and this does help us to see whether our treatments are working for these patients. The other questionnaire that's to your right is known as the SPEED questionnaire. Now, this is a little bit quicker to perform, and it's also a little bit quicker to grade. This is something that we can use clinically to rate a patient's symptoms and then to see how severe their symptoms are. This is a little bit more about the feelings of their eyes rather than activities. So it asks about dryness, grittiness, soreness, burning, eye fatigue, and then the frequency of that, and then the severity of that. And as well as it actually asks whether they use eye drops on a regular basis. So with all that said, I'm going to briefly discuss the current treatments that we have for dry eye disease. Now, if you talk to any ophthalmologist or optometrist, the first line therapy for treatment is always going to be a tear substitute or an artificial tear. These can include drops, they can include gels, they can include gel drops, or they can even include ointments at nighttime. There are preservative-free artificial tears that you can use for patients that have to use drops more than 4 times a day, because preservatives that are found in a bottle can actually cause counteractive dryness. So what I mean by that is patients that are using preserved artificial tears more than 4 times a day can actually worsen their dry eye when they think they're actually healing it because of the ingredients that are found in the artificial tears. So those patients, I usually recommend using a preservative-free tear, and those are the ones that come in those individual vials that you throw away after 24 hours. For patients that can't put drops in, there are things called Lacrocert that we can actually instill into the lower lid that will then slowly diffuse over time. And that can provide patients with lubrication, but it does require them to come into the office to put that in or to have another medical professional do it. Other treatments that can be done, now these are also sort of first-line therapy for evaporative dry eye or meibomian gland dysfunction, are warm compresses. Now, a warm compress is essentially you just take a hot washcloth, put it under as hot of water as you can stand it, and then you apply that to your lids for 3 to 5 minutes twice a day, and that helps to sort of liquefy any of these thickened meibomian gland secretions that we saw. The way I describe this to patients is what you have coming out of your oil glands now is more like Crisco or butter. And what we need to do is make that an olive oil consistency. When you need to melt Crisco or butter, what do? You heat it up. That's the same thing that a warm compress is going to do. Now, the problem with using a hot washcloth is that does not hold heat very long. Usually it holds heat for a minute at the most. So therefore you can get these lid warming eye masks like the one on the left, the upper left picture, which is called Eye Soothe, or there's something called a Brooder bead mask. Now, this is something that you can actually put into the microwave that holds heat for about 15 to 20 minutes, and therefore patients find it relaxing, they find it comforting, and so they can just place that on their eyes before they go to bed, and then that will help to liquefy the thickened meibomian gland secretions. I do recommend patients to do eyelid massage following this, because once you liquefy that thickened meibomian gland secretion, you want to get that out onto the tear film. So The nice thing about the washcloth is that you can actually provide massaging as well as heating. The masks are a little bit harder to provide that massage, but if patients hold it on for 10 to 15 minutes, you can take the mask off and then just gently rub your lids, and that will get the eyelid to secrete that good consistency meibomian onto the tear film. Other treatments, now these are more pharmaceutical in nature. Topical steroids. So these are things called prednisolone or fluorometholone. There's actually one that is FDA approved, known as Isovis. These can be used in short periods with patients that have moderate to severe inflammation. So these are very symptomatic patients. They work relatively quick after a drop or two. They get patients feeling better right away, and they work really well. The only problem is that they come with a bunch of side effects. The biggest one is elevated intraocular pressure leading to glaucoma. So you don't want to trade their dry eyes for a permanent disease like glaucoma. It can also hasten the formation of cataracts. Now, cataract is something that everybody will get, which is just clouding of the lens in the middle of the eye. However, most folks get that after the age of 60. Patients that are on topical steroids, you can actually hasten that formation so that potentially they may even have cataract surgery at the age of 40. And that's really not something that a patient wants to hear, is that they now have to have surgery on their eyes because of the treatment that they were undergoing for dry eye disease. The next sort of therapy that we can offer are topical antibiotics. So things like bacitracin ointment we can place on the eye at nighttime that helps to decrease good bacteria, which will then decrease inflammation on the eyelids, that inflammation reduction will then help with patients' dry eyes. Now, the problem with topical antibiotics is it's sort of hit or miss of whether it works or not. And then additionally, you have the problem of leading to drug-resistant bacteria. For really hard to treat meibomian gland dysfunction, I do offer oral antibiotics. Now, it's interesting because people usually think antibiotics are just for infection. In the case for ophthalmologists, we're using oral antibiotics to decrease inflammation. So doxycycline has a potent anti-inflammatory effect to it, which is why we use that. So we're using it for a short course, usually no more than 2 to 4 weeks. And that really does help to decrease the inflammation at the eyelid level, which will then help to get the meibomian glands working better. The problem with oral antibiotics is that it can cause skin burns or photosensitization. It can upset the gastrointestinal tract, leading to diarrhea and or nausea. And then it can also lead to yeast infection. So we like to sort of use this sparingly if we can. Additionally, patients that are pregnant cannot use oral antibiotics, or in women that are breastfeeding, because it can actually hurt the infant. Additionally, it does have effects on other medications, especially for patients that are on blood thinners. Next, I'm going to talk about the FDA-approved therapies for dry eye disease. Now, these are all topical drops. The first one is Restasis and Cequa. Now, Restasis was actually FDA approved roughly 25 years ago, and it addresses the inflammatory component of moderate to severe aqueous tear deficiency. So when Restasis was FDA approved, they actually found an improvement in the Schirmer score, which is one of the reasons why we do Schirmer score for basically every clinical trial. Cequa is cyclosporin, and it was FDA approved about 3 years ago. Now, this is actually double strength Restasis, essentially. It also has a different sort of modality of how it delivers a cyclosporin into the eye. So therefore, it theoretically can work better than Restasis does. The biggest problem with Restasis is that it can take months of using it twice a day to achieve symptom relief, and that can frustrate patients because they're looking for a relatively quick fix, but Restasis takes about 2 to 3 months to start working. The other problem with Restasis is that it can have up to a 50% failure rate. So 1 out of every 2 patients are going to fail Restasis. And again, that's going to be a big problem for patients that are looking for some sort of relief. Finally, with Restasis and or Cequa, the biggest side effect is stinging upon installation. And sometimes this is enough for a patient to want to stop taking this. The next drop I'm going to talk about is Xiidra. Now, Xiidra was FDA approved 6 years ago. We were fortunate enough to be involved in the clinical trials for the approval for Xiidra. Now, Xiidra is a different anti-inflammatory than Restasis and Cequa, so it works a little bit differently. One of the biggest selling points of Xiidra for me is that it actually improved the corneal surface. So it helped to get rid of the dry spots that we saw that you could see with fluorescein at about 12 weeks. Additionally, it works markedly faster than Restasis does. Patients can see symptom relief as early as 2 weeks, and that can last over time. The problems with Xiidra are the side effects. Dysgeusia is actually a bad taste in your mouth. So there were 30% of people in the FDA clinical trial that actually had enough bad taste in their mouth that they wanted to stop using the drop. Folks that take Xiidra also do complain of having a reduction in their vision. So for about 10 to 15 minutes after putting the drop in, they can see a decrease in their vision, which does clear up after some time, but that can be problematic for patients that put the drop in and then have to go to work or get home and put the drop in and then can't see for 10 to 15 minutes. So that can be a reason why patients discontinue Xiidra use. Additionally, just like Restasis and Cequa, since it is a pharmaceutical agent, it can lead to stinging upon installation. And Xiidra does have that, although patients tell me that it's not nearly as bad as Restasis is. Another FDA-approved therapy is primarily only for meibomian gland dysfunction. This is a procedure that we do in the office called LipiFlow. Now, this is heat and pressure to the inner eyelids. The machine does heat up to 109 degrees Fahrenheit, and then it's pulsed. So for about 12 minutes, you're getting massage of the eyelids to get rid of bad meibomian gland secretions. This is just an activator that goes on patients' eyes. So the benefits to LipiFlow is that it can restore meibomian gland function, and this is FDA approved. It applies heat and pressure directly to the inner eyelids for 12 minutes, and this is done in the office. This is just a slide showing improvement in a patient's meibomian gland score. You can see at 3 months, there was a statistically significant improvement in their meibomian gland secretion. And this lasted for 12 months at least with one single LipiFlow treatment. So one single 12-minute treatment. Most importantly, for our patients, there was a decrease in the mean OSDI score. So the higher the OSDI score is, the more symptomatic a patient is. So you can see after 3 months, there's a statistically significant improvement in a patient's OSDI score. So that means that their symptoms did improve after one single LipiFlow treatment. And this was maintained over a 12-month period. Other treatments for severe dry eye, I'm going to briefly go over these. Punctal occlusion is essentially what you're doing with that. The puncta is the tear drain, essentially. So tears are made from the lacrimal gland, and then they run into the lids. You have a puncta in the upper lid, you have a puncta in the lower lid. And what you can do is you can place drain stoppers in those puncta, which will then allow for the natural tears to accumulate, as well as any drops that you might put in will actually stay on the surface of the eye longer. Now, these are procedures that are done in the office. You can actually use collagen plugs, which are temporary. They dissolve within days. Or there's 6-month thin plugs that you can put into the tear drain that will last for 6 months, but have to be replaced every 6 months. Silicone plugs are actually more of a permanent, quote unquote, treatment because they do not dissolve at all. The only problem with them is that they can be manually displaced by patients pulling down on their lids, or by simply rubbing their eye. They can displace those silicone plugs because there is a little stopper at the top that can be dislodged. As far as the next bullet point, these are autologous serum eye drops. Now, this is an eye drop that patients can place. Now, this is a natural treatment, if you will, because what happens is you get a blood draw from your own body. A lab then spins that down. You take the clear serum on top, and then you dilute that into an artificial tear that a patient can then place on their eye. Now, the advantage to doing serum eye drops is that you're actually putting anti-inflammatory factors made by your own body right onto the surface of the eye, and this can actually help to heal the ocular surface. It is relatively expensive, but if a patient does not want to use something pharmaceutical, this is always an option for them. I should mention that serum eye drops are not FDA approved. This is something that we use off-label. As far as other treatments, this is sort of a more conservative treatment, omega-3 fatty acids. Now, that's something that you can get at any of your nutritional stores. You can get them at any of your big box stores. You can get them at CVS or Walgreens. The data is conflicting on whether this is actually beneficial or not. Now, if you see in one of my bullet points, it says in one study, use of 1,000 milligrams, which is one pill of omega-3s, 3 times a day for 1 year was found to improve symptoms, tear film stability, and meibomian secretions. So there can be some benefit to it, but that is an awful lot of omega-3 fatty acids for a patient to take. So when a patient's asking me about omega-3s, I say that they're not FDA approved for dry eye disease, but if it's something you would like to try, it can't hurt. It may not improve your dry eye disease, though. Finally, I'm going to talk about the newest FDA-approved therapy for dry eye disease, and that's essentially what I'm going to talk about here is neurostimulation. So 34% of our basal tear production is due to inhaled air through the nasal passages. This is just a schematic showing that the trigeminal nerve can be accessed in the nose, and then this will provide a reflex signal to the lacrimal gland as well as to the goblet cells, which make mucin, as well as to the meibomian glands, which produce the oil. And this can then make tears, a good quality tear that's on the surface of the eye. This is TruTear, which was FDA approved, and it's an electrical stimulator that's placed into the nose to activate the trigeminal nerve. Now, after day 7, after 1 week of using the TruTear for twice a day, you can see that there was a statistically significant improvement in the Schirmer's tear production. And essentially what that means is that a patient is making more tears just by using this for 1 week. Unfortunately, Allergan, which is the producer of TruTear, decided to pull this product from the market. You can read here that TruTear is a device developed to temporarily increase tear production during neurostimulation in adult patients. After careful consideration, Allergan has made the decision to stop manufacturing the TruTear device effective immediately. This has nothing to do with the safety or efficacy of the product. It was just essentially a commercial flop because it was very hard to convince patients to stick an electrical device in their nose to help with their dry eyes. Having said that, this led to production or to the development of the newest FDA-approved therapy for dry eye disease called Tyrvaya. Now, Tyrvaya is a nasal spray that does activate the trigeminal nerve within the nasal cavity, but this is a much easier sell for a patient to be able to use a nasal spray twice a day in order to help with their dry eyes. Now, we were fortunate enough to be one of the clinical trial sites that led to FDA approval of this Tyrvaya. And now it has been commercially available for over 9 months. And I can say that it has been a relatively big clinical success. And for patients that have severe dry eye, they now have another option rather than just putting more drops on the surface of their eye. I'm just going to briefly talk about various clinical trials that we have been involved with, as well as doing a quick clinicaltrial.gov search of things that are in the pipeline for dry eye disease. Now, one thing I have not talked about that's not currently available to us is actual healing of the cornea. A company called Regentry has something where they are looking to not just decrease inflammation, but they're actually looking to improve the corneal surface as well as heal the cornea that is caused by severe dry eye. Another company called Mitotech, which is a novel antioxidant, can decrease inflammation, which can actually improve the corneal surface. Now, the Mitotech drug is actually approved for dry eye disease in Russia. It's currently in its phase 3 clinical trials here in the United States. There are anti-inflammatories in the works. Isuvis, I mentioned briefly. This is already FDA approved to decrease inflammation. This can only be used for up to 2 weeks at a time, and it does help with the signs and symptoms of dry eye disease. The problem with Isuvis is that it does have to be dosed frequently, so 4 times a day, but it offers patients something that can be used for flare-ups of dry eye disease. The most common adverse reaction was just burning upon installation, but this was only reported in 5% of patients. So this is something that's commercially available that I do prescribe. Other anti-inflammatories that are currently in its phase 3 clinical trials, Aldira has a relatively potent anti-inflammatory, as well as Orinia, Novaleak, as well as an interesting one, Acthar Gel, which is already FDA approved for things like infantile spasms, MS exacerbations, symptomatic sarcoidosis. This is a systemic anti-inflammatory that is actually delivered via subcutaneous injection. They're looking to get it FDA approved also for dry eye disease. There are other exciting therapies that do not include other anti-inflammatories. Alista has an adiponectin analog, which will then have beneficial wound healing properties. Now, this is currently in its phase 2B and 3 clinical trials. There is a company called Aerie, which has other pharmaceuticals for that have ophthalmic conditions, and they are looking to help with getting into the dry eye market. Now, interestingly, with this Aerie compound, it actually provides a cooling sensation, so this may help to reduce pain and discomfort associated with dry eyes. Finally, there is a inflammatory condition known as Demodex that is prevalent in 69% of dry eye patients. Now, what the Demodex is essentially a mite that can be found at the lash follicle or at the lash base, and this can then lead to inflammation on the eyelids, leading to dry eye. Currently for Demodex, we have no FDA approved treatment. And so when I'm talking to a patient that I have identified with Demodex mites, really all I have to offer them is lid scrubs or cleansing of their eyelids. However, this is just temporary, and it's not something that actually cures them of these Demodex mites. There is an exciting new therapy that could potentially be, it's currently undergoing its phase 3 clinical trials, and we are fortunate enough to be one of the clinical trial sites that did demonstrate cure of these Demodex mites after 1 month of use. So you can see on these pictures here, a baseline, you have these almost waxy appearing sleeves at the lash bases, which then are completely gone after twice a day using of this compound made by this company called Tarsus. So I'm looking forward to this. It is, as I mentioned, currently undergoing its phase 3 clinical trials, and will hopefully go to the FDA relatively soon. With all of that, I would like to thank you for your attention. I will now turn it back over to Mark Prussian for the question and answer session.
Thank you, Dr. Pitar. That was very interesting, and I was very pleased to see some of the many clinical trials that you have worked on. We've had a number of questions come in through our Q&A chat function. If you haven't asked your questions yet, we encourage you to do so. In the time we have remaining, which is just a few moments, we're going to attempt to answer a couple of those questions. So Dr. Pitar, the first question is from a sponsor. You have described, Dr. Pitar, many of the trials that you have participated in. Can you tell us how you end up hitting enrollment goals for each of these trials? What techniques do you use to reach enrollment?
Thank you for that question. That's an excellent question, and that is one that we have worked very hard on. So as far as enrollment goes, as Mark mentioned earlier, the Butchertown Clinical Trials is a subsidiary of our medical practice known as the Eye Care Institute. And so it takes both our medical practice as well as our clinical trials practice to sort of work in concert to identify subjects in order to meet enrollment goals. We have a relatively robust database based on our medical records, as well as patients that have participated in previous clinical trials, that basically we can hone it down to something like a Schirmer's test. If we've done a Schirmer's test on them, we can see patients that will fit this specific inclusion criteria, or even patients that just have meibomian gland dysfunction that have been identified either through our medical practice or through other clinical trials. So we're able to really utilize our electronic medical records plus our electronic clinical trial records in order to help hit enrollment goals based on whatever sort of condition that we're looking for. Mark, I don't know if you have anything else to add to that or not.
Thank you for that correct and very accurate explanation, Dr. Pitar. We have a question coming in now from a CRO. Can you tell us about your data integrity measures when you input data into an EDC, please, and how your facility works for that?
Yeah, we are fortunate that we have a relatively large clinical trials team. So obviously, one of the most important parts of doing these clinical trials is, number one, subject safety, and then number two is the integrity of the data. So we place a very strong emphasis, whether it be with our clinical research coordinators or even our data analysts that we have in our office, that they hold the utmost integrity in converting paper records to the electronic data. Additionally, one of my most important responsibilities as a principal investigator is to ensure that the people that we have delegated to do these do it fairly, equitably, and trustworthy. And so we do not take that lightly at all. And so the clinical research team that we have here works very hard to make sure that everything we do is with the utmost integrity.
Dr. Pitar, thank you very much for that. This is all the time we have right now. We do have a number of additional questions that have been submitted by the chat function. We will answer each of those in about 48 hours by text, phone, or email, whatever you have left us. Thank you for coming to our seminar and listening to us today as we talk about our role in dry eye disease at Butchertown Clinical Trials. Thank you, everyone. You can contact us at 502-219-7700 or info@butchertownclinicaltrials.com. Thanks and bye.